Good morning and welcome to today's NCPDP webinar. Part 1, the Real-Time Prescription Benefit Inquiry, Introduction and Overview of Business Requirements and Use Cases. NCPDP is a not-for-profit ANSI-accredited standards development organization with over 1,500 members representing virtually every sector of the pharmacy services industry. NCPDP's vision is to lead the industry in healthcare standards and solutions for the common good. For Q&A purposes, you can ask a question at any time during the webinar today by typing in the questions pane on your GoToWebinar toolbar. All questions will be addressed at the conclusion of the webinar as time permits. After the webinar, you will receive an email with a PDF copy of the slides presented today, a link to the recording, and any necessary handouts for comments. Today's speakers will be Catherine Graff, Principal at Sonora Advisory Group, and Laura Toper, President of Granada Health. I will now turn today's presentation over to Kathie. Kathie?
Thank you, Wendy, and good morning, everyone, or I guess for some of you it may be afternoon now. It's a pleasure being with you today and to be presenting to you on the first of this series of 2 NCPDP webinars. We'll be providing an introduction and overview of the business requirements and the use cases for the real-time prescription benefit transaction that is envisioned for the future. We'll be defining what that transaction is and is meant to accomplish. We'll be providing an overview of what we call the real-time prescription benefit use case document, which defines those business requirements and use cases. And we will be outlining for you the timeline and the next steps to move from the use case document and on to an eventual standard. But first, let me give you a little background on the task group itself and its activities. The Real-Time Prescription Benefit Inquiry Task Group was formed in 2014. At that time, there was discussion about our current NCPDP formulary and benefit batch standard that's available to prescribers, but it has a number of limitations, and the most significant of those being that it doesn't describe the patient's specific benefit and responsibility, financial responsibility or cost share at a specific point in time. In other words, it's not a real-time transaction, but simply a representation of the patient's benefit plan. During the EHR certification rulemaking process, CMS requested comments from industry on the feasibility of a real-time patient-specific benefit communication to prescribers. And this task group was formed to address that and to develop the primary scenarios, or use cases as we call them, where real-time information would be most advantageous to the prescriber and the patient at the point of care. After identifying those use cases, this task group surveyed industry to understand from industry what industry perceived to be the priority of those task groups, and we of those use cases, excuse me. And then the task group identified 12 scenarios or use cases in which to focus our efforts for the initial version of a standard. The task group's not responsible for developing the standard, but for developing these business requirements and use cases, including the data elements that would be shared. And at last count, after over 100 task group calls, we have this use case document available for you to review with those 12 initial use cases. Next slide. There are many interested parties that are impacted by this initiative. In addition to those stakeholders on the right, the patient probably being the most important one, we have the participants or the stakeholders on the left, which we identify in the task group as participants or actors. We call them actors. These are the people that, or the participants that are actively involved in the transaction itself as envisioned by the task group. And they are the EMR or EHR system vendor or e-prescribing system vendor, optionally an intermediary or a switch used for routing that transaction between the prescriber and the processor PBM adjudicator, who is also an actor. I'll use those words interchangeably. I'll throw in the word payer once in a while. We're talking about the same entity, the person processing what would be a claim from a pharmacy, but in this case, it's the inquiry from the prescriber. And of course, the prescriber themselves, a provider in the use case document. So the stakeholders on the right will continue and have been involved in all of these task group calls and have participated in the surveys and are at work group meetings and such. So these are the industry stakeholders for this transaction. Let me step back a minute and talk about why we decided to put these two webinars on for industry. Why did we want to hold these webinars? We greatly need your engagement at this point in our process. We have a use case document drafted. It will likely become the foundation for a future standard. We've got over 250 people, I think, registered for this today, and we need your input, especially if you have not been participating in the development of this use case document. We're asking you to review it carefully and to answer the following questions. Is there an important use case that we have overlooked, something that should be in that initial standard? Do we have a scenario, for example, where prescribers need prescription benefit information that we omitted in the 12 use cases that we have documented? Are the business situations in the use cases that we have drafted properly documented? Is the information that we have envisioned to be on the request and the response for each use case, the request from the prescriber for information and the response from the payer PBM, is that information the information that's needed to properly determine the benefit of that patient and the appropriate therapy and the patient's estimated cost share or financial responsibility? So we need you, in reading this document, to think about those questions and to utilize the comment sheet that is provided to you with the document and provide us with your feedback. Next slide. I mentioned the batch formulary and benefit standard available through EHR vendors today a moment ago, and it does describe formulary drugs and copay information, but that is really not enough. Prescription benefit plans have more coverage limitations and more formulary restrictions in the past, and that is part of the problem that we are solving with this new real-time prescription benefit transaction. Providers need patient-specific benefit information before prescribing. Perhaps the patient's in a coverage gap, if they're a Med D patient, for example, and their financial responsibility or their out-of-pocket cost might be greater for some period of time. The prescriber and the patient really need to know that at the point of care prior to a prescription being written. So that's when they can determine what is manageable for that patient financially, because it might impact therapy and their choice of pharmacy. So today the prescriber may not know what's on the top of this slide, if the medication is on the formulary, if there are quantity limits, if authorization is required prior to dispensing the medication, if the patient cost share is manageable. All of these things we address in the use case, in the 12 use cases in the use case document. Next slide, please. So this transaction simply is a means to provide that patient-specific prescription benefit information to the point, at the point of care, to the prescriber and the patient. It is a request for information that originates from the prescriber at the beginning of the prescribing process, is received possibly through an intermediary or switch, by the processor PBM adjudicator, who then in real time provides a response back to the prescriber on that request. This is when I say prescriber and provider, I just want you to know I'm using those terms interchangeably. We're really talking about the prescriber with this transaction. Next slide, please. So the benefits are immediate. If you envision the fact that at the point of prescribing, the prescriber is requesting this information and getting a response in real time in a matter of seconds, you can see how most of the issues that are faced when a prescription gets to a pharmacy are eliminated because those decisions are being made at the point of care. The patient's able to pick up a prescription at the pharmacy now, knowing that the drug is covered, that authorization has been given, and anticipating what the prescription cost might be. It facilitates the discussion between the patient and the provider at the point of care on the most appropriate drug and the most appropriate pharmacy, and if there's a difference in cost of therapy from one pharmacy to the next. Studies show that if the patient goes home and waits for another prescription, for example, if an authorization is needed or there needs to be a switch in therapy because the drug isn't covered on the formulary, studies have shown that frequently the patients never come back and pick up their medication, which leads to the third major benefit, and that is reduced prescription abandonment. Since patients and physicians have verified the drug is covered, address the cost up front at the point of care, the patient's more likely to commit to the therapy, pick up the prescription, and therefore it's anticipated that medication adherence will improve. Next slide, please. So we have this use case document that we're asking you to read, and to be prepared, it's a 70-plus page document. What is this? This is the work product of the task group, and it is designed to capture the business requirements, as I said, of those 12 use cases that are envisioned to be in the initial real-time prescription benefit standard. It describes the act of the provider requesting the real-time benefit inquiry and the process and scenarios under which a processor would send a response, whether that be an affirmative or a negative response, and we'll talk about those. The next slide shows how the document is organized, and there are really two components to the document. What we call global content, which is about 20 of those 70 pages in the document, and then the 12 use case specific information, which is the other 50 or so pages of the document. The global content addresses assumptions that we make in creating the document, the scope of the document, definition of terms, and at a high level what's included in an affirmative response from the processor PBM. In other words, this drug is covered, this pharmacy is in network, this patient is eligible, or a negative response from the processor or PBM, and all the things that could be wrong, if you will, with that envisioned prescription. The task group recommends that you start from the beginning of the document and read that global content and those definitions first. And then, as you go through the use cases, which are described on a use case by use case basis, the data requirements, the process flows, what data is in that request and response, and the pre and post conditions within that use case, they'll be more understandable to you. Next slide. So I'm going to talk a little bit about some of that global content in the use case document now, and then after I have completed describing that global content, Laura will focus more on specific use cases at the end of this webinar, as well as in part 2, which is on the 13th, and a little bit more detail is provided at that time as well. So here are the major assumptions we make in this document that were agreed upon by the task group in creating the use cases. We make an assumption that the provider EHR system allows providers to submit a request and receive a response. In other words, the provider EHR system or e-prescribing system has to have the ability to have the functionality to do this. They must submit a request, receive a response. Excuse me. We make an assumption that this is a real-time transaction. So the response from the processor PBM comes back within seconds. At that moment in time is the response that is received. The patient's coverage, the patient's eligibility at that moment in time. So if for some reason the patient doesn't fill the prescription immediately and in the interim would lose eligibility or enter into a coverage gap, for example, then their experience at the pharmacy or their patient responsibility at the pharmacy may be different than what they were told at the provider's office. So this is an important assumption to contemplate, that it is at that moment in time, this is the response on that patient. It is a patient-specific response. All requests look the same in terms of the information that's on a request. In other words, when the prescriber is sending that request, the data elements that the prescriber is sending out of the EHR or e-prescribing system looks the same. It is the response that will vary depending upon what use cases are invoked of those 12 use cases. So responses look the same questions are being asked. It is the requests look the same, the same questions are being asked. It is the response that can look different depending upon the use case. If multiple use cases exist, in other words, if the patient needs a prior authorization for this drug and the patient needs to go to a restricted pharmacy because it's, for example, a specialty drug, if multiple use cases exist for a single request, it is envisioned by the task group, and the task group recommends that the response from that PBM payer address all applicable use cases. You can see that if there was a single request and a single response for one edit and then a second request and a second response, this would be quite cumbersome for the prescriber. And so we want to avoid that undesirable situation where a prescriber would submit a request and learn it's not on the formulary, for example, and then submit a second request for a prescription that was on the formulary, but then learn that it needs to be filled at a specialty pharmacy. We want to avoid that situation. So multiple use cases may apply to a single request. And then all use cases in our assumption document, all use cases assume that an intermediary or switch can be used, but they are optional participants. Next slide. We've already pretty much touched on everything that's in scope in this document. Patient-specific drug benefit information, information that's in a provider request, information that's in the processor response, product alternatives, and the fact that this communication must be real time. But I want to spend a few minutes talking a little bit about what is out of scope in this document and why. Out of scope are any real-time prescription benefit inquiries from patients. For example, anyone other than a provider. Out of scope is the actual or estimated cost of the product to the payer, just to the patient. Out of scope is the identification of the subscriber. We're only identifying the patient in this use case document. Out of scope are coordination of benefits. For example, when a multiple prescription benefits exist for a given patient. And out of scope are inquiries for services like medication therapy management or other services, inquiries for partial fills, or inquiries for compounds. Now, these are all important things that a prescriber may wish to know, and these could very well be valid use cases. And NCPDP may revisit these exclusions in the future version of the standard. But the task group surveys showed that the desire to get a national standard completed and soon was more urgent than including these less frequent or more complex use cases. Next slide. So here are the 12 use cases. We have patient eligible, product covered. That's the happy path, as we call it. The product is covered, the pharmacy is in network, and the patient is eligible. The second use case is the patient is not eligible or cannot be found. So eligibility cannot be determined. The third is a benefit exclusion. And I'm not going to go through the definition of all these use cases. Laura's going to spend a little time on those that may not be familiar to you. But a benefit exclusion, for example, is specific conditions or services or supplies or treatment for which the health insurance plan doesn't provide any coverage at all. That's a benefit exclusion, as opposed to a formulary exclusion. We have number 5, coverage limits. Use case 6, step therapy is required. Use case 7, prior authorization is required for that medication. Use case 8, the pharmacy is out of network. The requested pharmacy is out of network. Number 9, the provider, that is the prescriber, is out of network. There are situations where the provider is not contracted and therefore is not eligible to write a prescription for this patient. Use case 10 is a situation where the patient is locked into a specific provider. Use case 11 is a drug utilization evaluation or DUE alert for the patient, where the claim would likely reject at the pharmacy, and we're telling the prescriber that perhaps maybe multiple drugs have been prescribed for the same therapeutic category, or some other condition exists that the provider may not be aware of and would want to resolve prior to prescribing. And number 12 is restricted pharmacy use case, where the payer PBM has determined that the pharmacy identified in that request isn't eligible to fill this product for this patient, and that there's a restricted network for this product. So those are our 12 use cases that we'd like you to review. In reviewing those use cases, some things that will help you are that we have various segments that we have defined that would be in a request and a response. As I mentioned before, all request transactions require the same segments for every request transaction. That is the routing information, the payer routing information, transaction-specific information. This describes the transactions, it's technical information. Information on the patient, information on the prescription that's contemplated, information that's the pharmacy of choice, and information on the prescriber or provider, as we call. It is the response information that can vary by use case, but request transactions all require the same data. I seem to have missed a page. Did I go over situational, required, and optional? Thanks. All data elements are defined as either required, situational, or optional, and all segments are defined as either required, situational, or optional. Segments or data elements that are required must be included in the transaction. For example, the patient information is always sent. Information that is situational is actually required under certain conditions. So if those certain conditions are met, then that segment or data element is situational. For example, if the request was for a product that has a coverage limit, in the response, coverage limit is situational. If the edit was hit because the coverage was too much, then it would become required that the response included the maximum quantity amount. And segments can be optional, which are or data elements, which are included at the sender's discretion. And an example of this would be if the payer PBM wanted to send more information that wasn't in a discrete field, they can use the free text message area of the response. So I already mentioned what request transactions require. So I'll move on to what affirmative responses require. All affirmative responses, and let me remind you that an affirmative response is the happy path. It's the only time where the response is affirmative, where the drug is covered, the patient is eligible, the pharmacy is in network, and those affirmative responses require the routing segment, the routing information, the transaction-specific information, the prescription information as submitted is echoed back on the response, and the estimated patient financial responsibility, which is the patient cost share. Any additional information that the payer PBM chooses to send on an affirmative response or sends on an affirmative response is either situational or optional. For example, if in the case of a pharmacy that is in the network and it's a retail pharmacy, the payer PBM might elect to send additional information on a mail service pharmacy option. So that would be up to the payer PBM if they would want to include that information on that affirmative response. Negative responses require that same routing information, transaction information, and prescription information as submitted, but negative responses also require the reason for the negative response, the reject or denial explanation. So all negative responses will tell the prescriber why there is an issue with this prescription in that reject denial explanation, the reason why the negative response was sent. Now, that reason, that denial, that explanation will vary, of course, by use case, but it will always be sent on a negative response. The other segments on the next page are also on a negative response, but are optional information based upon the use case. Financial information can be provided as total financial responsibility as required, but situationally, more detail about financial information may optionally be required. Coverage limits are optional information unless the use case requires it. Drug utilization evaluation information, alternative pharmacies, lock-in prescriber identification, all this information is considered optional and dependent upon the use case as to what it needs to be provided. So with this, I know you're probably feeling a little overwhelmed about the detail, but hang on, I'm trying to provide you with some information that once you see the use case document will help you make more sense of it. And Laura's going to give you some examples now that will aid you in reading through the document. So I'll turn it over to you, Laura.
Thank you, Kathie, and hello, everybody. Thanks for hanging in there with us. So as you go through the document, which we sent out just before the webinar began, you'll see that for each use case, we have a description, we have preconditions of process flow and post conditions. And then we've identified all of the information that we think is necessary for that use case. So when you start going through this, did we describe it correctly? Are all of those conditions and process flows properly defined, or is anything confusing, or did we miss anything? And then, please take a close look at, of the information that we've listed, have we clearly said this is required, or is it situational, or did we list something as optional that you think should be required or situational? So it is, as Kathie said earlier, it's a little bit of a lengthy document. It's a slog to get through, I will acknowledge that, but I do think it'll be valuable, and your review of it is what we need to make sure that we are on the right track. So if we move to the next slide, what I'll do is very sort of high level walk through a couple of the use cases. So use case one, as Kathie said, is it's the happy path. Provider submits the request, it's routed to that processor PBM who takes a look at it, they process it, and they send an affirmative response back to the provider. We've got no issues, you're good to go. And if you take a look on the next slide, we've got a little bit of a pictorial that just, everybody learns differently, so we have words and we have pictures. So over here, the provider's working within their EHR, they've got data capture, there's a display, they send that request. Again, optionally, that could be going through an intermediary or switch for routing to the processor for review. They're going to send it back as affirmative, and they're required to send back that patient's estimated financial responsibility. So that's the nice, simple, easy use case. If we move on to use case 2 on the next slide, this is the patient is not eligible. So again, the provider is submitting the request, it's routed to the payer PBM, and then they send a negative response. And because, as Kathie stated earlier, this is a point in time, we're saying that right now, when we've gotten this request, this patient is not eligible for pharmacy benefits on the day we got it. It could be because they're no longer eligible, or I can't find the patient, or they had coverage on the 30th of the month, but you're submitting a request on the 2nd of the month, and that coverage is no longer in effect. So if we go to the next slide, you'll see the graphical representation of that. It's the same flow, but coming back, the only message that the payer is able to send is that the patient is not eligible. So there's no financial information coming back because I don't know the patient, I don't know what their benefits would be. All I can tell you is this patient is not eligible at this point in time. We move on to the next one. We've got a benefit exclusion. And so, as Kathie said, this is a situation where the product that's being requested is excluded. There's no alternatives. It's a contract exclusion. We've all seen them. I'm assuming some of us have actually read the certificates of coverage, but oftentimes it's a complete class of medications that might be excluded, be it investigational or perhaps infertility, those types of things where there is no coverage. So they're going to submit that request, get the response back. Again, the message will simply be that there's a benefit exclusion. We're not going to give you any financial information, nothing else. We're simply telling you that this product is not covered for this patient. And then if we move to the next one, this is a little different. This is the formulary exclusion. And so the request is submitted, it gets processed, the PBM sends back that negative response and says, you requested product A is not on our formulary. However, the processor can, if they so choose, send back information on alternative formulary products that are covered and what the patient's financial responsibility for those. And so if we look at the graph, what you'll see is, again, the same flow. The required information that comes back is formulary exclusion. So hopefully that's displaying as bolded on your screens. And then alternatives and financial responsibility are optional, and the processor can send those back if they choose. So those are 4 of the use cases. The remaining use cases, coverage limits. These are items or situations where perhaps the quantity or day supply that the provider is requesting exceeds what the plan will allow. This could also include age or gender edits. So you've got a product that's the patient's identified gender is female and it's a product that only males would use, or perhaps we've got an age edit, be it a high-risk medication for the elderly or a pediatric. Those would all fall under coverage limits. Step therapy is a situation where the plan has established that certain products need to be tried and failed before the requested product would be approved for coverage. So the plan would have the ability to send back, you can't have this product until A, B, or C are tried first. Prior authorization required, I think most folks are familiar with, which is where the plan has set up parameters that must be met before coverage for that product will be granted. The intent or the hope is that for those systems that are able to use electronic prior auth, when the real-time prescription benefit response comes back and says, oh, prior auth required, the systems will help then start deriving the use of that EPA transaction. So, oh, I got a message back that prior auth is required. I'm going to start the prior auth process for my patient immediately. Out-of-network pharmacy, pretty straightforward. It simply is notifying the prescriber that the submitted pharmacy is not in network for the patient, and so there isn't coverage, or there may be lesser coverage if the patient chooses to fill the medication at that pharmacy. Out-of-network provider, similar concept. That provider is not contracted within the plan, so medications written by that provider are not going to be covered, and the patient will have to choose if they wish to pay cash. The patient-provider lock-in is that situation where plans will have those programs if they feel the need, based on experience and practice with the patient, that patient needs to be seen by a provider or perhaps a set of providers. And this could be compliance-driven. It could be if there are concerns about fraud or abuse. And so the message would come back and say, you know, you're not authorized to write for this patient. They need to be seeing, you know, Dr. Jones. On the DUE alerts, use case 11. Again, the plan is going to look at the information that they have on file, so their claims history. And if that requested product is going to somehow cause a conflict with something that's already on that patient's profile, be it therapeutic duplication, overutilization, or some sort of drug-drug interaction, that message will go back to the prescriber so that they can take a look at it, perhaps contact the other provider and say, you know, we need to take this patient off of this drug and start them on that, and somehow resolve that alert. And then our last use case 12, is that of a restricted pharmacy. And this covers a couple of things. It could cover if, similar to a provider lock-in, the patient has been restricted to a certain pharmacy or set of pharmacies. It could cover situations where the plan's network, maybe for a specialty product, says you can't get that at your corner store, you need to use our specialty pharmacy. So we looked at a number of different things to do that. It could also be that maybe the plan doesn't offer a retail benefit, it's mandatory mail. And so the message would come back again, the submitted pharmacy is not going to be able to fill for this patient, here's the pharmacy that can. So it's a way to get the prescriber information on what pharmacy they can send that script to. Go to the next slide, please. So next steps. Again, what we need from you is to really take a look at that use case document. As I said, you should have gotten it in your in-basket right before we started. Did we miss anything? We came up with these 12 scenarios or use cases based on, you know, the 100 calls that we've had with dozens and dozens of participants, the survey that we've done of the industry, but maybe we've missed something. So if we have, we want to know that sooner rather than later. Have we clearly and properly documented all of the business situations? And then, is the data that we've identified for each request and response enough for the prescriber to be able, for the payer and the prescriber to determine the benefit and cost, and then have those conversations? So we'll ask you to please take a look at that. The comment form is there to sort of streamline everybody's work on this, so you're not, you know, sending emails, but if you can get those questions and comments back to Sue Thompson by October 18th. We will be discussing this in a face-to-face meeting at our work group meetings in Atlanta on November 3rd. So if you're available to join us, please do. There is registration required, and we can get you more information on that. Go to the next slide, please, Wendy. We just wanted to give you a little bit of a sense of the process. So we're going to get all of this input. We're going to review that within the task group. It will be posted for those of you who are members and have access. It'll be in the work group folder so that you can review the documents and all of the comments prior to work group. When we meet on November 3rd, we're looking for a vote which says use case document's good to go, or it needs more work. And that's part of our standard NCPDP process, is to just get that membership approval before moving forward. Once that's approved, and we're hopeful that will happen on November 3rd, we will submit what is known as a new project development form, which is part of our process to move this forward, that project development form would then essentially request that we start working on actually building the transaction. And so that is what we're hoping for, and we'll start building it, and we'll come up with the detailed standard, the transactions, the implementation guidance. Depending on the technical structure, there could be schemas associated with it. All of that won't occur until we get the use case document approved and the project development form approved. So that's what we have to look forward to. And then, Wendy, I think we're opening it up for Q&A at this point.
Okay, thank you, Laura and Kathie. Our first question, has NCPDP ever considered working with HL7 on using the FHIR standard to exchange this information?
I can take a pass at that. This is Laura. I think the short answer is yes. The longer answer is the task group really hasn't delved into the technical structure yet. So whether we look at EDI, XML, or FHIR, we don't know. But it's certainly an option that I think is open for consideration.
Okay, thank you, Laura. Our next question. Will these RTPBI be ran through X12, 270, 271, or will there be a new transaction set specific for this inquiry?
This would be a new transaction.
Okay, our next question. If the response is real-time, why would be Happy Path response include an estimated patient financial responsibility as opposed to a guaranteed patient financial responsibility?
Good question. A couple of reasons, because it's the request at the time that the prescription is being considered. It's not at the point that the prescription is being filled. So there could be another transaction that occurs in the meantime. So I could be at the doctor, send the request, and by the time my pharmacy processes that subsequent prescription, maybe I've had another claim go through that could affect my accumulator. That's one part of it. I think the other piece of it that we're taking a look at is the prescriber doesn't necessarily know what product the pharmacy has in stock, and so they might be using a representative NDC for that request as opposed to what is actually dispensed by the pharmacy. So, you know, obviously the goal is to get it as close as possible, but there are simply some data issues that preclude that from happening.
Okay, thank you, Laura. Our next question, can you speak to the principles behind determining required versus optional fields on the response? It is a hard balance. It would be good to describe to the group the method the work group used initially to recommend.
You want that one, Kathie, or do you want me to take it?
Roger, are you on the line?
Yes. So I think the answer to that one was we were looking at mostly on the inbound request, what would be absolutely minimally necessary for a PBM to process one of these transactions. And if it was minimally necessary, it became, you know, is designated required. And then, of course, is what is the additional information on the inbound request that a PBM might need, but not all PBMs might need to process the request. And then, of course, what we did is sort of the opposite, is looking at scenario-specific use cases to determine what is absolutely needed by the prescriber on a response, and then what would be sort of situationally defined in those scenarios.
Thanks, Roger. And for folks that don't know, that is Roger Pinsino, who has been one of the 3 tireless co-leads of the task group effort for the last couple of years. We have more questions, Wendy?
Yeah, thank you, Roger and Laura. Our next question, I am a pharmacist working at a technology company. We've been trying to connect to PBMs for patients' pharmacy benefit, the one that EMRs have an access to today. SureScripts has, with the RTPBI transactions, how can we ensure that PBMs don't restrict access in a way that would not connect and they would be forced to use a specific vendor? Should I reread it to make it a little clearer?
No, I think I'm okay. I think, what we're trying to build is a transaction standard for the exchange of information. Everything that NCPDP does from a development perspective, all of our meetings, all of our task group calls, certainly follow antitrust guidelines. So I'm just a little concerned that the question might be something that's outside the scope of what NCPDP can or can't do. We're building this transaction with the concept or the assumption that use of an intermediary switch is optional, but we're presuming, and we wrote it into all of the use cases thinking that would happen. But as to any entity that's a part of the transaction trying to manage that traffic flow, I think that's outside anything that NCPDP can control.
Okay, thank you, Laura. Our next question, do one of the use cases cover if a pharmacy is preferred in the member's Medicare Part D plan?
Not a specific use case, but there is envisioned to be the ability to send back an indicator as to whether or not it is a preferred pharmacy.
Okay, thank you, Laura. Our next question, I may have missed this, but is the idea that this would be an addition to the script standard, or is this a new standard?
This is Kathie.
Oh, sorry, go ahead, Kathie.
This is a new standard. If you think about the prescriber workflow, during the decision-making process as to what therapy to write a prescription for, this would occur prior to the electronic prescription being written. So this transaction would occur to determine whether or not this drug is on the formulary or all the other questions that we mentioned. Assuming an affirmative response, to make this simple, assuming an affirmative response, then the e-prescribing activity would begin in workflow. If you had a required authorization, prior authorization, as Laura mentioned, ideally workflow would then initiate that authorization request electronically, which is part of the script standard, and then ultimately, after the authorization is obtained, then initiate the electronic prescription. So this would really, envisioning workflow, this would be the first of the messaging that would occur in that prescriber's workflow most often.
And I think what we've tried to do is look at what elements already exist within an NCPDP transaction, be it, script or our telecom, our claims transaction, so that, we're trying to be consistent with the reuse of data information so that, we're not adding and creating unnecessary new data elements. And as I said earlier, we still don't know what the structure will be. So the script standard is based on XML. Other standards are based on EDI, or the question earlier to FHIR. We don't know yet about that, but it would be a new transaction, as Kathie said, from the prescriber to the payer.
Thank you, Kathie and Laura. Our next question, would this information be available for companies other than the prescriber, like third-party billers or pharmacies?
Kathie, you want to take that one, or you want me to?
Well, that use case has not been contemplated in this document. Just like the use case of using this for patients, it was out of scope in this document. It is possible that future versions could have additional actors.
Can I just add a little bit to that? This is Bruce from Ben Medica. Again, I think Laura said this earlier, that this transaction that is being created is all about the transaction itself, not who the trading partners are. And trading partner agreements are outside the scope of NCPDP.
And Bruce is another one of our co-leads. I think that's fair. As you read through the use case document, though, you'll see that on the request, we're looking for provider information. And so, to Kathie's point, you know, future iterations could certainly involve other participants or other actors. But I think we'd need to know who that requester is so that the processor knows who they're responding to. So. Other questions, Wendy?
Okay, we have two more. Does the pharmacy indicator indicate in-network or preferred pharmacy?
So the pharmacy information that's envisioned to be included on the response would identify or confirm that the submitted pharmacy is in the patient's network. We've got the use case for out-of-network pharmacy. And again, we're looking at that indicator for preferred, non-preferred. I think we're capturing what the questioner is looking for. But if not, please comment on the use case document and let us know.
All right, next question. Is the goal of NCPDP to build and provide this technology, or is this group simply conducting research to create the standards this product might adhere to?
NCPDP is a standards development organization, so we are looking to create the technical standard for the exchange of the information.
Okay.
And not a solution that somebody would plug and play.
Thank you, Laura. And our last question, can optional data on a request be made required by a particular PBM/payer?
This is Kathie. The optional data on a request or on the response? Because I don't believe, I would have to look back at the use case document, but I'm not sure there is optional data on a request.
Yeah, I mean, the request is pretty straightforward. To Roger's point, it's what's the minimum amount needed for the processor to handle the request. So, you know, routing and transaction information, we need, you know, they need to know who the patient is and some information there. They need to know about the product that's being requested and the attributes associated there, and the pharmacy and the provider. So I don't know what there is other information.
There is some situational data on the request, and it is very minimal, such as patient's middle initial. So that's situational. In other words, it's required if there is a middle initial, otherwise it is not.
Yeah. So, I mean, that would be something we'd love to have more feedback on. I don't know if whoever asked that question is thinking along the lines of from a claim perspective where the PBMs deliver payer sheets to the pharmacies and say, yeah, I know it says optional, but I need it. So if that's the thought process, we'd love to understand more about that when you submit a comment. All right.
Okay, and that's all our questions. Go ahead. Wow. Would you like to make some comments?
Sure. No, thank you all very much. Those were great questions. We appreciate your time. Hopefully, you've got that document in your inbox. Any feedback is welcomed. We've got another webinar, as Kathie mentioned, on the 13th, where I will be going into much more specific detail on a number of the use cases, getting into a little bit more of the granularity of what are the elements that are required on some of those transactions. So if you haven't yet registered for that, please do so. And again, as I mentioned, for the work group meetings in Atlanta, this will be discussed on November 3rd. Registration is required. I think members are all pretty familiar with that process. If you are a non-member, please feel free to go out to the link or send an email to Sue Thompson if you've got questions about attending, and we can help you through that. And then we'll keep you all posted. And then, Wendy, we're sending out the link after this with the recording, correct?
Correct. We do have another question that did come in. I think we may have addressed this, but why develop a new transaction instead of incorporating this into the script transaction?
So again, go ahead, Kathie.
I was just going to say the script transaction, if you're talking about the e-prescribing transaction, that is a transaction that occurs between the prescriber and the pharmacy. This is between the prescriber and the payer PBM processor. It's a different actor.
Well, I mean, within script, EPA does go between the provider and the payer. I think, again, we structurally don't know if this is going to build off of script or not. I think that big technical piece is still out there. Regardless, there's a significant amount of content that needs to be built that doesn't exist right now consistently in any of our transactions. So we have to build something new to support this, the same way we built EPA, the same way, you know, we've enhanced any of our standards over the years. So that's the distinction. All right.
So what you're saying, Laura, is it may become, but it hasn't been decided, but it may become one of the suite of transactions within script.
That is correct. But we don't know where we're going to end up yet. You know, again, the goal of the task group to this point was, what are the business requirements? What are the use cases? What are the data elements that we believe are needed? Once that gets approved by the membership and we move through the SDO process that NCPDP follows to maintain our accreditation, then we get into, I suppose, the next layer of sausage making, which is, okay, now we actually have to build the transaction. We have to write the implementation guidance. We have to figure out all of the technical requirements. So stay tuned or join the task group or both.
Okay, thank you, Kathie and Laura, for the time and expertise you shared with us today. For more information on our speakers, please visit our website, ncpdp.org, in the education section, and you can read full biographies on both of our speakers today. That concludes today's NCPDP webinar. You will receive a follow-up email shortly with a PDF of the slides presented today, a link to the recording, a draft of the use case document, and an Excel spreadsheet for comments that can be returned, as Laura instructed earlier, to Sue Thompson by October 18th. Please join us for Part 2, Use Cases and Next Steps, next Thursday, October 13th. Thank you all for your participation, and have a great day.